Sir, it's live.
Hello, friends. My name is Dr. Parag Dekate. I am Director of Pediatrics and Head of Pediatric Intensive Care and ER at KIMS Cuddles, Kondapur, Hyderabad. We do run Pediatric Intensive Care Fellowships. And today we are going to talk about a very simple but yet complicated topic, that is fetal circulation and transition. There's a lot of discussion about fetal circulation when we talk about what you called as congenital heart diseases. So we have to really understand how this fetal circulation, just to see how we can see there are different manifestations as well as different presentation of the congenital heart disease, whether it is duct dependent circulations or any other things. So we should know how this fetal circulation. So I'm going to talk in a whole topic about this 6 points. So how is your fetal circulation? There are different characteristics and uniqueness of the circulation. There are different shunts and its characteristics, oxygenation characteristic, how oxygenation differs in whole of the fetal circulation, how much is the total cardiac output, and how it is kind of a segregated all over the blood vessels, ventricles, atrias, and how we have achieved ventricular separation, and then we go from a fetal to neonatal circulation transition. So we will see through that. So this is basically your fetal intrauterine circulation. So what exactly happened? You know that there is a placenta over here. In placenta, you have two umbilical arteries and one umbilical vein. So what happens here is the umbilical vein is carrying an oxygenated blood, goes inside, and you can see there is a two bifurcation of an umbilical vein. So one of them attaches towards the right portal vein. That means what happens? The most 50% to 40% of the blood supply from umbilical vein goes from this to portal vein, which is basically a venous circulation when you are inside the womb or in a fetal circulation. And almost 55% of the blood bypasses this and through the ductus venosus goes into the what you call as the inferior vena cava, and then it goes into the right atrium. Once it goes into the right atrium, there is some mechanism which we are going to talk about. There is a preferential blood going into the left atrium through the ostium secundum or the lower part of a crista terminale. So what happens? It goes inside the LA. From left atrium, blood goes to the left ventricle, then get ejected. Simultaneously, the right ventricle, which receives some blood from the inferior vena cava, superior vena cava, coronary sinus, which crosses the tricuspid valve, goes into the right ventricle, and then right ventricle eject this blood into pulmonary artery. So once it's go into the pulmonary trunk through ductus arteriosus, again it comes back to the descending aorta. So you have some forward flow through the left ventricle into the arch of aorta. Some blood goes above, which perfuses the brain. Some goes down, which again mixed with the blood coming from the right ventricle through the ductus arteriosus, and then it perfusionates all the body. And again through the umbilical arteries, it goes back into the placenta for reoxygenation. Some blood doesn't go back into the umbilical veins. What happens is there is a blood which is going into the lower limb and genitalius and all those things. That blood come back through the inferior vena cava, again goes back into the right ventricle. So you can see, you can consider there is kind of a communicating each with one is atrial septal defect, one is patent ductus arteriosus or ductus arteriosus, and ductus venosus. So, and the fourth major important shunt is a placenta. So these two parallel circulations are connected with each other at four places. One is ductus arteriosus, atrial septal defect or ASD, or you can say ostium secundum ASD, ductus venosus, and placenta. So these are the most important shunts you see in the intrauterine life. So what is the uniqueness of this fetal circulation? This fetal circulation is very, very unique. As I told you, there is a parallel circulation happening, and both the circulation come together and exchange the oxygenated and deoxygenated blood depending upon the shunts where they are actually exchanging their blood. There is a ventricular dominance here. Ventricular dominance means the left ventricle is not playing much of a role here. It is mainly the right ventricle which is dominating the circulation here, because the blood from the right ventricle goes to the ductus arteriosus and supply all over the body. Intercirculatory connections, as we discussed, it could be a foramina ovale, ductus venosus, placenta. All those things are really important. One thing which is very, very unique for this fetal circulation is pseudostiff. The ventricles are pseudostiff. They behave like they are not contractile at all, or they are less contractile, or they have a less relaxation. What do you mean by less relaxation? Means they don't expand too much. So they are pseudostiff because they are not exposed to the good pressure in the intrauterine line. And there is a limited range of a heart rate which can improve the cardiac output. That means we know that in the neonatal, adult, pediatrics, there is a way of increasing the cardiac output. So cardiac output is basically what the stroke volume into the heart rate. So if you increase your heart rate, there is a possibility that you will increase the cardiac output. But in the fetal transition or fetal circulation, there is a less ability, because the ejection is actually not contributed mainly because of the stroke volume. So these are the few uniqueness of the fetal circulatory physiology. Other things is there is a partition non-oxygenated and oxygenated blood. So there is a partitioning of both the things, and you might have seen it. There is a different kind of a shunts which actually mixes oxygenated and deoxygenated blood in a different concentration. We'll talk about it. This is very important. Work related growth of chambers. So chambers in the sense you can say RA, LA, RV, LV, how much they work do, accordingly there will be a growth of this. So it's not like that. If you have a continuation of this fetal transition, there will be no growth of a RV and LV. So you definitely need some amount of work to improve their growth. Say simultaneously, blood vessels. So the hormone which is responsible for the blood vessel growth is called as vascular endothelial growth factor. So how this vascular endothelial growth factor is secreted is, this is all because of the pulsatile flow of a blood. So pulsatile flow into the arteries is really important. So if you have a pulsatile flow, then there will be a secretion of vascular endothelial growth factor and the vessel will grow. If you have a continuous flow, so continuous flow in the sense, just imagine like extracorporeal membrane oxygenation, where there is a continuous flow. So there will be no growth of the vessels because there will be no secretion of this vascular endothelial growth factor. On top of that, if there is no pulsatile flow, the vessels, the endothelins, will secrete a lot of bad hormones or bad cytokines, which are absolutely not good for the body and might cause a leaky or systemic inflammatory response syndrome. So remember this, there has to be some work. It could be a pressure work or it could be a volume work for the chambers to grow. And there has to be a pulsatile flow for the great vessels to grow. So intrauterine, the pulmonary vascular resistance is exponential. It's very, very high. That's why we have a very little blood flow to the lung. So almost 10% of the cardiac output goes into the lung. From the lung, it come back from the pulmonary veins back to the LA. Very, very little. And the systemic vascular resistance, all of us know, the resistance of the most of the systemic blood vessels is very low in the intrauterine. The reason for that, for us, it is really, really, really important to maintain the blood pressure. But this is SVR is very, very low in the intrauterine life to maintain the perfusion. And why it is low is because of the placenta, because it secretes a lot of prostaglandins and other vasodilatory hormones which keep the SVR very, very low. And there are right to left. So if you see intrauterine and post-uterine or neonatal transition, intrauterine, all the shunts are from, most of them are right to left. While if the same shunt persists in the neonatal transition, it will be left to right because left pressure increases significantly, while in the intrauterine, right pressures are more. And that's why this shunt are left to right, and which is very important for the oxygenation. So as we discussed, there are four shunts. One is ductus venosus, ductus arteriosus, foramina ovale, and placenta. And we are going to talk about each of them. So ductus venosus, as you know, I just told you in the previous diagram, there is an umbilical vein, single umbilical vein, which bifurcates into two. One is the ductus venosus, which connects this umbilical vein to the inferior vena cava. And there is another small vessels, which actually diverts the bloods into the portal vein. Ultimately, this blood vessel changes into the ligament of Teres. And you can see the amount of oxygenation depending upon the line. So red one is a high oxygenated blood. Medium purple is basically medium content around 55. and this one is lower less than 50. So what happens in a ductus venosus? Schematic representation, what you can see, there is an umbilical vein, and there you have a small kind of a sphincter over here, then ductus venosus, which connects into the inferior vena cava. Some blood goes into the liver through the portal vein. So 50% of the blood coming from the umbilical vein goes to the portal vein into the liver, from liver again back into the IVC to the right hepatic vein. 50% of the blood directly goes into the inferior vena cava. So it's a highly oxygenated blood going directly from umbilical vein to the inferior vena cava, while the highly oxygenated blood going into the liver through the portal vein get utilized by the liver, and then deoxygenated blood through the hepatic vein goes back into the IVC. So really important, 50-50% here, and there is a preferential flow depending upon the trajectory of flow. We'll talk about it. There is a sphincter in the umbilical vein where actually it enters into the body at the what you call umbilicus, as well as there is a sphincter at the ductus venosus also, because immediately once you clamp the umbilical cord, what happens? The prostaglandin secretion goes down, and there will be a no flow system through the umbilical vein, and there will be a sphincter constriction at the ductus venosus, and ductus venosus will close. So you can see the specimen here. There is an umbilical vein. Then you have a portal sinus where there will be a small vessel arising, which is going into the portal vein, which actually perfuses the liver. And then again, this blood, which is perfused by the umbilical vein through the portal vein, goes back against into the inferior vena cava through the right hepatic vein. But some blood preferentially bypasses this, that is approximately 50%, goes into the inferior vena cava, which is a highly oxygenated blood. We can see this echo picture. You can see in this echo what is happening is, you can see there is a, again I will play. This is basically inferior vena cava, and then you can see there is a blood vessel going, one blood vessel is going towards here, which is basically a portal vein, and some blood is directly, again I will play so that you understand, and the blood is coming back into the inferior vena cava. This is basically a ductus venosus. This is a fetal echo. So ductus venosus, what happens is, ductus venosus is a reduced impedance circuit. So basically it helps. So there is a possibility that if there is a connection between the umbilical vein and the portal vein has a less resistance, then the preferential blood will go into the hepatic vein and into the liver. But what happens over here is, there is a reduced impedance in the ductus venosus. That's why the preferential blood goes into the IVC through the ductus venosus. So which helps to passage this highly oxygenated blood from umbilical vein through the ductus venosus into the inferior vena cava, which is really important. So as you saw, as I told you, you can see the umbilical vein coming up, and then you have an arcuate branch where it is connect with the portal vein, and it perfuses the liver, while there is a blood which is going through the ductus venosus directly into the foramina ovale. So umbilical venous blood, sir, is predominantly distributed to the left lobe of the liver. Remember that. Arcuate branch to the right lobe of the liver. There is a selective streaming of the blood seen in the thoracic portion of the IVC. We will talk about it. What do you mean by selective streaming is that this oxygenated blood, which is on the left and probably a posterior aspect, goes directly towards the RA and through the foramina ovale, gets shunted towards the LA, which is a selective streaming of the blood. As you discussed, anterior and right portion has poorly oxygenated blood. So you can consider this is as a poor oxygenated, the gray one, and the black one is a good oxygenated. So what happens is, right-sided and anterior blood preferentially goes into the RA and then goes into the RV. But the posterior streaming of the blood, the left and the posterior, directly through the inferior vena cava, gets streamed towards the LA through the foramina ovale. And that is really important to transition this bliss. You can see that there is a selective streaming of the blood through the lower part of a crista dividens, and the blood is going into the left atrium, because we want more oxygenated blood should goes into the LA so that it goes into the LV and then into the brain. So let's talk about another shunt, which is foramina ovale. So what happens is the inferior vena cava comes and the blood goes into the RA. From RA, it goes into the LA through the foramina ovale. There is a preferential flow to LA through the foramina ovale. We'll talk about it, and we spoke. There is such an arrangement that the blood coming will directly go towards the LA. So you can see the lower part of this stream the blood coming from the IVC into two portions. The maximum goes into the LA, few remains into the RA, which goes into the RV. And major flow happens through this into the LA. Let's talk. You can see that there is an inferior vena cava, and when the blood goes, because of the lower part of the crista dividens, it is spitted like that. The blood, which is posterior and left side, get transition toward the LA. So good oxygenated blood get transition towards the LA, and maximum blood flow goes toward the LA, so that the blood doesn't have to go to the RA, then RV, then lung, and all those kind of stuff. So you can see the crescentric edge, crista dividens overlies on IVC. So it is like a schematic representation. You can see it is absolutely in the middle of the IVC. And 27% of the total cardiac output passes through foramina ovale. So whatever the amount of blood which is ejected by the left ventricle, the 27% comes to this foramina ovale. So you can see this foramina ovale, there is a transition. You can see there is a small black kind of thing you see here. You can call it as a here you can see small that this is called as a foramina ovale, and here also you can see the blood going and coming. You can see here is the so RA is coming on this side, the blood is going towards the LA. Now talk about ductus arteriosus. So we know ductus arteriosus is a connection between the pulmonary trunk and the arch of aorta, and intrauterine. What happens is the maximum blood ejected by the RV, only 10% goes into the lung. Rest of the blood through the patent ductus arteriosus goes into the descending aorta to perfuse the other part of the body. But once the transition happens, once the baby is born, 90% of the ductus arteriosus close by day 4. Out of that, 20% by 24 hours is gone, 80% by 48 hours, and 100% by 4th day has to be closed. Why it happens? Just imagine the ductus arteriosus is not closed. What will happen? There is a lot of blood going into the lung because the lung pressure will drop down. And what happens is the shunt, which is right to left, intrauterine, will become left to right because the aortic pressure will be more than the pulmonary pressures. So the blood will come into the lungs and lungs will get flooded. So this is basically a protective mechanism to prevent the lung from flooding. At the same point of time, once it is closed, it helps the right ventricle to strengthen and function better because it is not that I would say hypertrophied. So it will help the RV to pump blood into the lungs. And ultimately what happens, this part which actually closes turn into a small ligament, which is fibrous ligament over the time. You can see here, this is an arch of aorta, and this is basically a pulmonary artery, and you can see a connection here. Again, I will play. So this is a pulmonary artery. This is an arch of aorta. This is a connection is called as a patent ductus arteriosus. This connection is called as a patent ductus arteriosus. Now, what exactly happens over? So you know that this circulation is a low PO2 circulation. So you can consider this is a basically a pulmonary artery, and there is a very low level of oxygen because it's a low oxygen system when you are intrauterine. And there is a high intraluminal pressure. So because of that, the blood vessels are flattened and bigger. At the same point of time, there's a lot of prostaglandin E, which is secreted by the placenta. This prostaglandin E will be utilized or digested into the lung, but we know that there is a very less 10% of the blood flow going into the lung. So prostaglandin stays in the body for a longer time, and that is responsible for the relaxation of these pulmonary blood vessels, or you can say ductus arteriosus. So the vessels are relaxed, there is no hypertrophy, and the prostaglandin E is staying in the body for longer time. And same time, there will be a down regulation of the endothelians and cCAM, which is responsible for again keeping these blood vessels open and this endothelial cell flattened. So this is really important to be there during the intrauterine phase because most of the systemic blood to the lower part of the body is carried through the ductus arteriosus. So how this closure of channel happens, as we talked about different shunts, let's talk about the ductus arteriosus. So the closure of ductus arteriosus happens because of the oxygen. Oxygen is the most potent stimulus for the ductus arteriosus to close by. Simultaneously, there is a release of a, I would say, good kinins or a bradykinins and a smooth muscle constriction of the pulmonary blood vessels. At the same point in time, there will be a closure of this smooth muscles constriction of the ductus arteriosus. And what will happen is the placenta is separated from the body, because once the baby is born, you clamp the umbilical cord. So the prostaglandin E2 goes down, the blood goes into the lung, so get digested. So the prostaglandin E levels are less. And that is the reason, if you wanted to keep the duct open, we give prostaglandins. When we see the duct is open, it is because of the persistent hypoxia, acidosis, or there is a localized P2. So when we are giving any medications to take care of, to deliberately open the PDA, then it will be open. So it is not just about PO2 concentration, but the advancing gestational age is also a very important factor for closing this ductus arteriosus. What they have seen, any baby who is more gestational age, that means let it be any child of a gestational age of 38 weeks with the same level of PO2 as compared to the 36 weeker, has a higher chances of closure of a ductus arteriosus. So with advancing gestational age, even the low concentration, there is a more or a same degree of constriction. That means it's just not only oxygen, there are other things also which plays into while closing the ductus arteriosus. Now, what about ductus venosus? The ductus venosus close with the clamping of umbilical cord. There is no much utilization of the ductus venosus. There will be no flow because you're clamping the umbilical vein. So there is no flow going into from umbilical vein into the ductus venosus. At the same point of time, portal pressure decreases. So you don't require any transitioning of a blood into the portal circulation. So it's a very low pressure system. And when in the initial newborn period, if you wanted to put an umbilical venous line, so what happens is, you might have seen there is a small kind of a dent and it goes into the inferior vena cava. So it utilizes ductus venosus. So via ductus venosus, umbilical catheter through the umbilical vein, ductus venosus enter into the inferior vena cava. What about foramina ovale? So we know that foramina ovale can be persistent in 30% of the adult, but most of the time it's not significant and doesn't play a major role unless and otherwise it's very big. What about the blood flow dynamics happening into the blood vessels? So you can see in the pulmonary artery, only 10% of the blood goes into the lung. As I told you, the lung pressures are really high and the RV is not able to pump the blood into the lung. And we have a puff-off wall, which is the ductus arteriosus, when the blood goes into the descending aorta. 90% of the blood through the ductus arteriosus goes into the descending aorta. What about ascending aorta? 90% of the blood to the upper body organs. So once it is ejected from the left ventricle, it perfuse the upper part of the body, which is mainly brain, and 10% goes into the descending aorta, which mix with the blood coming from the pulmonary artery. What about the descending aorta? So you can see 65% of the blood through the descending aorta go back to the umbilical artery and then placenta. But 35% of the blood supplies the other organ, comes back to the inferior vena cava, goes into the RA. You can see the oxygenation content over here. What is happening is, this is a placenta, which is carrying 85% saturation into the umbilical vein. And you have an IVC, which is carrying 35% saturation. So what happens is, here, through the ductus venosus, the blood will go into the inferior vena cava. And the inferior vena cava saturation, IVC is having 35%, UV is having 85%, ultimate saturation you will see is almost 70%. This 70% blood will cross through the, what you called as a foramina ovale, goes into the LA. So 70% is going into the LA, you can consider. In LA, you are seeing some blood coming from the pulmonary artery, which is very pulmonary vein, which will be very low. And then you have approximately 65% saturation. So placenta umbilical vein 85, IVC is 35, umbilical vein through ductus venosus, just IVC and the left latrium saturation is 70%. From the left atrium, LV get oxygenated blood. So once it comes back to the LV, you have almost 65% saturation. Then you eject. So the upper body receives 65% saturation. You know that 90% of the blood will go into the upper part of the body. 10% will go into the descending aorta, which will be mixed with the blood coming from the RV. So here you have a 50% saturation because you have a 70% saturation over here, and then the SPC blood will come. deoxygenated blood IVC will come, and effective saturation will be 50%. Out of that, 90% will go through the PDA or persistent ductus arteriosus down into the descending aorta. So you have a 50 and you have 65. So approximate saturation in the descending aorta will be 55%. And then ultimately through these vessels, this goes back into the placenta. Now about fetal cardiac output. The combined cardiac output is around 400 to 450 ml per kilo per minute. Out of that, uteroplacental flow is 200 ml. That means approximately 200 ml of blood probably not goes into the placental circulation and not get oxygenated. So umbilical vein, blood 55% passes through the ductus venosus and 45% passes to the liver. Abdominal IVC drains around 30% of the cardiac output. That means 70% is coming approximately from the uteroplacental circulation, and rest of them probably is done by the native circulation, which is coming through the inferior vena cava. The superior vena cava drains approximately 20% of the cardiac output. So basically, 30% is coming from the IVC, 20% is coming from the SVC, 50%, and rest of the 50% is provided by the uteroplacental circulation. So let's see the segregation of this cardiac output in this schematic representation. So what is happening is you have a left ventricle and right ventricle. So you can see 35% of the venous return goes into the left ventricle, which contributes to the 35% of the cardiac output. And right ventricle contributes to almost 65% of the venous return and cardiac output. So through the left ventricle, you have three channels. One is going into the coronary artery. So almost 8% of the left ventricular outflow goes into the coronary artery. 63% goes into the arch of aorta and perfuse the brain and other organs, which is upper part of the body. And 29% through aortic isthmus can go down through the patent ductus arteriosus or through the descending aorta goes, which actually receives another 87% from the ductus arteriosus coming from the right ventricle. So right ventricle has two channels now. One is it will eject the blood into the main pulmonary trunk. Then through the ductus arteriosus, almost 90% of the blood goes into the descending aorta. Rest of the blood, which is 8 to 10%, goes into the lungs. So now we have a descending aorta, which is having approximately 10% or 29% coming from the left ventricle and rest of the things coming from the ductus arteriosus and right ventricle, which approximately corresponds to, you can see, out of that, almost out of the 63% of the descending aorta flow, 41%, which is two-thirds, goes back into the placenta, and 22% goes into the lower body, which again contributed by the right ventricular outflow as well as left ventricular outflow. So you can see the placental blood, you reasonably see. So they are approximately more blood from the deoxygenated blood coming from the right ventricle, which is less oxygenated, goes back to the placenta for oxygenation as compared to the lower body. It's a protective mechanism of the body to make it sure that the other organs are perfused well. So you can see how the left ventricle and right ventricle output plays importance during the perfusion. So what are the various aberrations of the fetal shunts? When we saw a fetal shunt, there has to be some aberrations which is going to happen. So pulmonary vasoconstriction, there is a possibility there is a pulmonary persistent vasoconstriction, which is absolutely bad. What we call as PPHN and all, it happens. It causes hypoxemia. Hypoxemia itself increases the pulmonary venous constriction. So it's like a vicious cycle. Acidosis, again, H plus ants, again, one of the very potent stimulus for pulmonary vasoconstriction, which itself causes pulmonary hypertension. And what happens is usually foramina ovale and ductus arteriosus shunts are postnatal or fetal, they are right to left. But postnatal, if you have pulmonary vasoconstriction, what will happen? They will become, they will persistent to stay right to left. So you have seen fetal circulation, they are right to left. But if there is a persistent of a fetal circulation after birth also, they will be right to left. So there might be a persistent of fetal circulation. There might be acidosis, hypoxemia, hyperlactatemia. All those things will make the things more complicated. Negative inotropic effect, heart will not contract well, and the PVR will go up. And here in this situation, all the treatment directed towards decreasing the pulmonary vascular resistance. So what we do? We give oxygen, we maintain the normal homeostasis, we try to get the pH up or make it proper. and we try to wash out the CO2, give more oxygen, give blood so that the pulmonary arterial hypertension goes down. So this is about the aberrations. At the simultaneously, we discuss initially the ventricles are stiff here because they are not doing much of a part. They are not actually getting exposed to volume as well as pressure. And for the development of the ventricle, as we discussed, pressure and the volume is really important. So we see a pseudo stiff ventricle when we are talking about the fetal transition. So here myocardium is immature. They have a low number of mitochondria, uh, less compliant. So they don't have a good diastolic relaxation. They are less responsive to the beta agonist. So it doesn't raise the heart rate as compared to the adult and pediatric. And the arrangement of myofibril is little bit sparse. So all those things makes the ventricle little bit stiff. But over the time, once you transition to the neonatal circulation, once the all channel closes, they get exposed to the volume and pressure and they start functioning well. About the functional dependence and separation, so you can see because of the presence of foramina ovale, we see almost equal arterial pressurization. If there is a ductus arteriosus, there might be a similar arterial pressure because there might be a depending upon which pressure is more transitioning or right to left to right shunt. Ductus venosus, which carries most of the blood into the right atrium and the right ventricle. This basically corresponds to the diastolic function of the right ventricle. Diastolic function is basically a relaxation. And what about the diastolic function of the LV? There is a some venous return through the LVC and SVC crosses and goes into the left ventricle. So all those things are dependent together. You can see, depending upon how much is the pressure, there will be a transitioning from one atrium to the another atrium. Depending upon how much blood is coming from the SVC to the IVC and descending aorta, both RV and LV are interdependent. So what exactly happen is LV is pumping to the high resistant arch of aorta and isthmus, and RV is pumping to the low resistant uteroplacental circulation. You understood that because RV blood 90% through the patent ductus arteriosus goes into the descending aorta, which is a low resistance circulation here. But once the baby is born, it becomes a high resistance circuit. But LV is pumping into the upper part of the body through the arch of aorta and isthmus. Depending upon that, we see a lot of things and which plays a different role in both RA and LV. So it can be a resistance of a placenta, ductus arteriosus, closure of foramina ovale, left ventricular outflow tract obstruction, which itself causes trouble with the LV, RV pumping into the descending aorta. Simultaneously, LV pumping to the high resistance circuit, we have different transitioning and aberrations, which is left ventricular outflow tract obstruction, mitral flow, which decides about it, how much blood is going into the LV, isthmal flow, how much flow, how is the isthmus, it is small, big, and simultaneously right ventricular outflow tract obstruction. So what exactly happens once we have a birth of a baby, how the transition happens? So once there is a birth, baby cries and take an alveolar expansion. Once the alveolar expansion happens, alveolar oxygenation increases and there is a fall in the PaCO2 and there is a significant fall in the pulmonary vascular resistance and the more and more blood from the RV goes into the lung. Simultaneously, there is a clamping of the umbilical cord. So what happens? You get separated from the low resistant placenta circulation. There is no more prostaglandin E2 in the circulation. And there is a subsequent increase in the systemic vascular resistance. So what is happening is, so systemic vascular resistance is increasing, PVR is falling. And because of that, the lung preferentially send the blood into the lung. RV preferentially send blood into the lung rather than through the ductus arteriosus into the systemic circulation. Once there is a fall in the PVR, more blood goes into the lung. Increased blood will come back into the left atrium through the pulmonary veins. And because there is a pressure, and we know that it's like a ball valve pattern, so there is a more pressure on this side. The crista terminally closes by. There is a closure of foramen of ovale, and there is no more right to left shunt. Cord is clamped. So what happens is ductus venosus sphincter constrict, blood diverted towards the hepatic sinusoid, and less pressure into the IVC and RA. So this happens because of the clamp closure. So we'll see this. So what happens is the cord is clamped, uteroplacental circulation is eliminated. There will be a significant fall in the prostaglandins. And simultaneously, what is happening is there are few breaths. Because of that, there is a fall in the pulmonary vascular resistance. And what is happening is there is a decrease or reversal of the ductus arteriosus flow because the PVR is dropping. So from systemic circulation, blood will come into the lung. Because of that, there is an increased pulmonary blood flow, more blood going into the LA, and there is a closure of foramina oval. And here what is happening is, because the placenta circulation is eliminated, there is a fall in the prostaglandin, ductal arteriosus constrict, it goes away because the oxygen is increasing, and ultimately there is a closure or functional closure of foramina oval, and you transition into the neonatal circulation. So from this fetal circulation, you going to the neonatal circulation, which are kind of going through the lung with the oxygenation happening simultaneously. And then there will be a rudimentary fetal kind of a transition, which ultimately converts into small of the ligaments. So initial breathing, what happens? There is an inflation of the lung, decrease in the pulmonary vascular resistance, increase pulmonary blood flow, which is really important because we want lung to go to the blood go to the lung to get oxygenated, which was initially in the fetal happening through the placenta. There is a progressive thinning of the walls of pulmonary arteries because, as I told you, the flow is really important. And during the fetal phase, there is only 10% of the flow going into the lung. Increased flow in LA and increased pressure in the LA, which closes the foramina oval. As PVR falls, flow across the ductus arteriosus reverses from right to left, it becomes left to right. And there will be a increased oxygen in the ductus arteriosus and it will close. And there will be a remodulation of the RV and LV muscle mass because of the persistent pressure and the volume overload. So this is the fetal. We can see this is blood coming from the umbilical vein going into the left heart. You can say like that. So it's a placenta. There is a more and more blood and the body blood coming back into the right heart through the foramina oval, crossing into the left part. Very less blood goes into the lungs. Through the ductus arteriosus is going to the descending aorta, and there is a forward flow into the brain through the left atrium. With the umbilical cord clamping, what happens? So there is a placental circulation is taken care of. Now the body blood has to go back. So you can see the blood which is crossing the foramina oval from right side to the left side goes down significantly. So during this time, we have to maintain the cardiac output. So how it maintained? It is maintained through the right heart, through the ductus arteriosus. You can see, because the less blood, once the placental circulation is less, what is happening is the less blood is going into the RA from the RV as well as through the foramina oval into the left heart. So that's why the blood flow comes down. You can see how big there is a blood flow. Blood flow for some time goes down, and subsequently then there are few initial breaths. And what happens is, then because of that, ductus arteriosus kind of started closing, and the shunt which is right to left become left to right. More blood going into the lung. Because of that, the left atrium inflates, closes the foramina oval, and then you come into the neonatal transition, which happens in probably you can say in the 3 stages. The pulmonary blood flow after, so you can see before a lung aeration is like a collapsible kind of a flow. You can see there is a rapid upstroke and downstroke. But once you have a lung aeration, because of the pulmonary vascular resistance and the right ventricular flow and the right ventricular maturations, you can have the nice flow here. So narrow upstroke, negative deflections because of ductus arteriosus flow or aorta. So there is a continuous kind of a flow happening through the ductus arteriosus into the descending aorta. And over the time, what happens, because there is no more rapid change in the pressure, because there is no more ductus arteriosus, and there is a good PVR and SVR as well as the right ventricular function, it becomes a broader systolic flow and it doesn't go into the negative deflection. This negative deflection corresponds to the ductus arteriosus flow. So what ultimately happened to the fetal shunt? Ductus arteriosus closes, ductus venosus also closes, umbilical vein, it becomes kind of a ligament of teres, which is sitting there without any canalicalization and without any flow. Umbilical artery proximal part persists at a branch of internal iliac artery, and distal portion as a medial umbilical ligament. So all those things go into the rudimentary phase. Different congenital heart conditions we see when we're talking about a duct dependent congenital heart conditions. So you have a duct dependent pulmonary circulations. Duct dependent pulmonary circulation means we need a duct to be open to take care of the blood flow to the lung. So we have a critical tetralogy of Fallot. We have a pulmonary atresia where there is no forward flow. So the blood flow depends upon the duct going into the lung. We have a pulmonary atresia with intact ventricular septum, critical pulmonary stenosis when there is no forward flow. We have a truncus arteriosus with pulmonary stenosis or pulmonary atresia. We have Seaver-Epstein anomaly where the blood flow, the PDA persists. Then you have a duct-dependent systemic circulation, where you have a hypoplastic left heart syndrome, critical aortic stenosis, coarctation of aorta, interrupted aortic gorge, shown complex. And then we have a poor mixing, where there is a TGA with interventricular septum. These are all duct-dependent congenital heart disease. Then we have a non-duct dependent, which are all actually not playing any part, and most of this patient doesn't have a duct. So these are basically mild and more cyanotic condition, depending upon which kind of a shunt we are seeing it. Most of the time, this shunt is at the level of ASD or VSD. So with this, there are different congenital heart condition. You can see what is happening over here is there is a duct dependent pulmonary circulation. So duct is persistent, and ductus arteriosus shunting from left to right, so that you can see there is a pulmonary trunk is very, very small. The pulmonary arteries are very, very small, and probably RV will be small. So there is no forward flow to the main pulmonary trunk into the pulmonary arteries. So what happens is the ductus arteriosus has to be open so that it shunt blood from the left side into the right side and maintain the pulmonary blood flow. Simultaneously, when we see the ascending aorta, which is rudimentary or interrupted aortic arch, hypoplastic left heart syndrome, coarctation of aorta, we really need this ductus arteriosus to be open, though it will be a deoxygenated blood, but it will definitely maintain the blood flow to the other part of the body. So this is called as a duct dependent systemic circulation, because if the duct is closed, there will be no forward flow into the whole of the body. So with this, I would like to rest my presentation. So my take home message here would be understanding the fetal circulation is important aspect for understanding the physiology and pathophysiology of the congenital heart disease and what we are going to do in this patient, how much saturation we are going to accept, what surgical route we are going to take. Differential distribution of cardiac output is there in a fetal and neonatal circulation, and understanding this is really important. Oxygenations varies significantly in the fetal circulation. There is one of the most drastic transition happening in the body when we are going from the fetal to the neonatal circulation. Remember, the transition are physiology and pathology specific. They are not just happening like that. They are really important, so that there is a different impact happening in the both circulation. Few transition takes the days, but the few transition happens immediately. Aberration in the transitions are common and might cause persistent of a fetal circulation. And understanding this is really important if you wanted to take care of these kids when they come to you in an emergency situation. Thank you for your kind attention, and see you with the next presentation. If you have any questions, you can actually ask those questions on the YouTube link or probably Facebook, or you can actually direct it to the DocTutorials. Thank you. Shall I stop sharing?
I'm stopping the session, sir.
Yeah, thank you.